Welcome back, students. Let's continue with the alpha blockers. First up, we are going to discuss this phenoxybenzaimine. Phenoxybenzaimine is a non-selective alpha blocker. It can block both alpha 1 as well as alpha 2 receptors. Postsynaptic alpha 1 and presynaptic alpha 2 receptors are blocked. And unlike other alpha blockers, they produce irreversible blockade. Phenoxybenzaimine forms very strong covalent bond with alpha receptors and they produce irreversible blockade. So the action is prolonged and they produce stable non-equilibrium type of blockade. They can also inhibit the reuptake of released noradrenaline. They can block receptors for acetylcholine, histamine, and 5-HT, which can produce sedation and drowsiness. They produce falling BP, which is mainly postural. So orthostatic hypotension is very common to see with oxybenzamine, and vasodilation or venodilation is more prominent than arteriodilation. They also produce reflex tachycardia. Reflex tachycardia is mainly due to blockade of the presynaptic alpha 2 receptors. So there is release of noradrenaline which can act on the beta 1 receptor which is producing reflex tachycardia. Phenoxybenzaimine can shift the blood from extravascular compartment to the vascular compartment and their blockade is slow onset. They produces blockade in 1 to 2 hours and longer duration, mainly for 3 to 4 days. The action will remain. Oral absorption of phenoxybenzaimine is incomplete and erratic. They have high lipid solubility and they can penetrate the blood-brain barrier. Phenoxybenzaimine is mainly used in pheochromocytoma. We saw pheochromocytoma in the part 1, where pheochromocytoma is a tumor of the adrenal medullary cells where there is excess release of catecholamines. So phenoxybenzaimine can be used in inoperable cases, malignant tumor, or before surgery it can be used. They can also be used in peripheral vascular disease. Adverse effects of phenoxybenzaimine, it can produce sedation, fatigue, hypotension, very common, postural hypotension. Flushing is commonly seen, tachycardia or palpitation is very common. Nasal congestion is also produced, meiosis, inhibition of ejaculation, and large doses can produce nausea, vomiting, increased excitability, and convulsions. Ergot alkaloid is another non-selective alpha blocker. So we have drugs like ergotamine, dihydroergotamine, ergotoxin all comes under ergot alkaloids. They are competitive alpha receptor blocker and they produce long-lasting vasoconstriction. So their effect is mainly by direct stimulation of the vascular and smooth muscles. But as an alpha blocker, it is not clinically useful. Their principal use is mainly in migraine. Another non-selective alpha blocker is phentolamine. So here again noradrenaline is released, which is produced venodilation more than the arteriodilation, and they are rapidly acting and they have very short duration of action. So they can be used in pheochromocytoma. They can be used to control hypertension due to clonidine withdrawal or cheese reaction, and can also be used to counteract the vasoconstriction due to extravasation of noradrenaline or dopamine during IV infusion. Coming to the selective alpha blocker, which is prazosin. Prazosin is a selective alpha 1 blocker. So the alpha 1 receptor blockade is much more than the alpha 2. They have very mild effect on the alpha 2 receptor. They are mainly or selective alpha 1 blocker and they produce arterial dilatation more than veins and they can block sympathetically mediated vasoconstriction and they produce fall in BP. Fall in BP means mainly postural, which is less marked, okay, and with or very less tachycardia. So reflex tachycardia is very less because they do not block the presynaptic alpha 2 receptor. That is why they have very less tachycardia. So prazosin produces what is known as first dose effect. Postural hypertension or orthostatic hypotension, usually it can occur as a first dose. So beginning of the treatment, it can produce postural hypertension and it can be minimized by starting with low dose and also taken at bedtime. So this first dose effect is very commonly seen with prazosin. Initially, with the beginning of the medication, postural hypertension is very common, and subsequently tolerance will develop. That is known as first dose effects. And prazosin can inhibit phosphodiesterase enzyme, and that can contribute to the vasodilation, same with prazosin. Pharmacokinetics is very, prazosin is effective orally, and they have mild duration of action and very short duration of action, and they have very mild side effects when compared with phenoxybenzamine and phentolamine. That is why they are better tolerated than phenoxybenzamine or phentolamine. So they can be used as, prazosin can be used as an antihypertensive drug, as an add-on therapy or a second line antihypertensive drug. Can also be used in congestive heart failure. They can also be used in Raynaud's disease, it's a peripheral vascular disease, and also BHP, benign hypertrophy of prostate. Another selective alpha-1 blocker are terazosin and also doxazosin. They share similar characteristics. Both of them have longer half-life, they are longer acting, and they produce apoptosis promoting effect on the prostate. So this effect on the prostate is unrelated to the alpha-2 blockade, and because of this effect, they may retard the progression of prostatic hypertrophy. Okay. So doxazosin and terazosin both can be used in prostatic hypertrophy and also doxazosin in hypertension. Next, coming to tamsulosin, it is the another alpha-1 blocker. So it's a uroselective blocker because it selectively blocks the alpha-1A and alpha-1B receptor. It is called as uroselective. So among them, alpha-1A receptors commonly present in the bladder base and prostate. So they can reduce the tone of internal sphincter of the bladder, and they can improve the urine flow, can reduce the residual urine in the bladder. Mainly used in benign hypertrophy of prostate. When you compare it with the drugs we discussed before, terazosin and doxazosin, they lack the apoptosis promoting effect on the prostate, but they are alpha-1A receptor blocker. That is why they are called as uroselective. Uroselective because this receptor alpha-1A is mainly present in the bladder base and prostate, and hence they are very much useful in benign prostatic hypertrophy. And they have greater potency in inhibiting the receptors in the bladder, neck, and prostate. So they do not produce much of heart rate, increase in heart rate or BP. So there is no significant change in heart rate and BP, and they are better tolerated in patients who continue to suffer hypertension with terazosin or doxazosin. Adverse effects, it can produce dizziness and retrograde ejaculation. Coming to alpha-2 receptor blocker. So the drug is yohimbine. So it's a natural alkaloid from this West African tree. Okay, so they block the alpha-2 receptors. Mainly the presynaptic alpha-2 receptors are blocked, and hence they can increase the sympathetic outflow and potentiate the release of noradrenaline. But they do not have any established clinical role. Thank you for your patient listening. With that, we complete the alpha blockers.